Hey, Adam.
Hey, what's going on, Kevin?
I think I probably had a slightly less busy day than you, but thank you for taking the time to join us today.
Yeah, happy to be here.
I thought I might kick things off, giving folks, everybody who's attending knows about the announcement, has gotten the details on that, but I thought I'd kind of give my quick read of the political article, how I understand it. Would be curious to then dig in a little bit to operating details of how the pilot's going to go, how you guys think about that, and then how it relates to the broader business. So my quick recap of what I've read in the Politico article this morning was excellent, provided a lot of really good context on the news, but y'all announced a pilot program in the state of Utah, process prescription refills for a defined set of medications where there's no human in the loop. So pure AI processing the refills, which seems like a huge step forward in many ways and something the industry has talked about a lot in terms of using AI and care delivery and when do we get to that point? So congrats on getting to there with the state of Utah. And part of what the coverage in Politico talked about was how the state mentioned they're excited about this initiatives because particularly in rural parts of the state, it could help lower costs, reduce medication lapses, improve access to care. And I thought that'd be a good starting point for conversation. Like any pilot, I am sure there are metrics that this looks at from a pilot perspective and how you think about scaling, whatnot. So I'd be curious if you could share a little on how you think about success of the pilot, what the state's looking at, how you are thinking about measuring that and scaling it over time.
Yeah, for sure. I mean, so let's start with the problem, right? Because the problem is going to tell us what data we're going to look at. I mean, the problem is not medication renewals. The problem is medication non-compliance, right? That's where the major issue is. And so, the statistics out there are pretty stark when it comes to medication non-compliance. If you don't take your medication, you have poor health outcomes. And the US government and insurers pay a lot of money for medication noncompliance. Like, in fact, estimates are that it's about $100 billion a year in poor health outcomes and misused health resources, right? So, very easy example. You don't take your medication, you show up in the emergency room, you get a $3,000 bill for a new medication. That's a waste of money, right? And
Yep.
so that is the problem we're trying to solve. And we do it by providing a infinitely accessible system, right? There's no waiting line. You can do, there's no supply problem. There's always enough AI doctor for you to renew your medication, no matter how many people want to do it. And so what we're going to be measuring is one, are people utilizing the system? That's obviously like a very baseline metric that we need to do. But two,
Yep.
are people staying compliant with their medication after they use the system, right? And so one of the things we'll be doing is after you come utilize the system, you'll actually, get a follow-up that says, are you taking your medications as prescribed? Right? Very simple question, but it actually is a very important piece of data. Have you gone to the emergency room within the last 30 days because you weren't on your medication or for some other health reason right there? That's also going to be a huge metric right there. And then the last one's also going to be have not just the last one, but the other big one is have you had to go see your primary care doctor because the medication renewal program was not sufficient for you to continue taking your medications. Those are sort of some basic things that we're going to be looking at there. I think then there's also the component of the end user, the patient. Were they satisfied with the system? Did they feel like the system was easy to use? All sorts of things like that. That'll inform whether or not we can improve it or not. But in the end, the state of Utah is most concerned about medication compliance.
Yeah. I'd be curious from an awareness perspective to that goal of getting people to utilize the system. As a health tech nerd, I have already gone on Doctronic AI and tried to convince you guys that I'm in Utah to use it.
Yeah.
Unfortunately, you guys are smart and have blocked me from doing so based on my location. But I imagine that folks in rural Utah aren't aware of Doctronic, don't know that this program exists. I imagine there's a lot of buy-in with providers in rural areas. How do you think about gaining traction, acceptance with both patients and providers in those parts of Utah?
Yeah, very good question. So I will just start off with like this has actually been live now for we did sort of a soft launch, did in the cover night just to make sure it worked. It's been live now for
Yeah.
3 weeks. Hundreds of people have actually come through the system already. And that just speaks to the demand out there. People actually have this is a big problem for a lot of people. There's a number of ways in which we can sort of find people and show them what we're doing. I think the easiest way is obviously how people find a lot of prescription renewals is online. You go online, you're trying to get a prescription renewal. We can target those patients quite easily. We do that today in all other 49 states, even in Utah, without doing it autonomously. We know that that works, and that's just a pure marketing strategy. The other thing is going to the point where the pain is the greatest, which is oftentimes the pharmacy itself. And so we actually went to a pharmacy in December and we sat down with them and we said, how are patients coming in? At what point do they actually have a problem? And how do we address that problem for them with the system, right? So a lot of times patients will call the pharmacy and say, I need a prescription renewal. My doctor is not available right now. That's an obvious, like, easy entry point for us. So we're in the process of actually going to pharmacies, one by one and saying, hey, this is available. It's a free service for you. We want you to tell your patients about it. It's highly accessible for them. So that's another way we can sort of get the word out. And then the other is just sort of the sort of mass market. We're going to do probably half a dozen interviews today of local news. Spoken to
Okay.
the Utah the Utah papers as well. We'll be going through hopefully some of the bigger players in the Utah health system, like Intermountain, University of Utah, all those places, so that we can share this information with people. This is one of those things where I think most of the stakeholders in this process actually want the solution. So patients obviously hate it when they can't get a prescription renewed. It takes them 2 weeks to see their primary care doctor. Pharmacists hate this too. They lose revenue when you come in and you can't actually get a prescription renewed. So they actually want something like this as well. And then I'm a practicing doctor. I know that there's no doctor out there that likes writing renewals for prescriptions, right? It's extra work. It's oftentimes very hard to get reimbursed for that. There's never been a doctor who's graduated medical school and said, I did this so I can renew more prescriptions. So you do have a lot of buy-in from lots of different stakeholders, and we just need to go to them one by one and essentially allow them to share that with their patients.
Yep. Um, I'd be curious as part of that process. So this initial pilot seems like it is a subset of meds that seem relatively low risk, well suited for these sorts of refills. How do you think about expanding that medication list over time, getting into more complicated refills, et cetera? Is that a near-term thing on the roadmap? How do you think about that as part of this rollout?
Yeah, to give you a sense of the formulary, how we got there, we started with the 300 most prescribed medications in the United States. We then had independent reviews by us, by independent pharmacists, and actually by the Utah Sandbox. And we removed things that we thought were a little bit higher risk. So no scheduled narcotics, actually no scheduled medications at all. Those were removed. Things for high risk diseases like ADHD, for instance, like high risk of abuse, we just removed those medications. And then we also removed injectables because we just felt like that was slightly higher risk as well. What was left was about 191 medications. Um, but it turns out that's about 80% of medications prescribed, right? So we're actually starting off with a really large piece of the like prescription pie, so to speak. Yes, I think over time, as we prove that this is safe, we'll expand that to other areas as well where we think it's safe. I mean, I don't see a reason why injectables couldn't be a fast follow to this. A lot of times, the people that utilize those are actually quite savvy. They understand how to use the medication. It's not a big restriction there. The diseases you're treating are pretty much the same as the ones you're treating with oral medication. So I would anticipate that would expand, and that's actually built into the program. Utah does this as sort of a collaborative process, and so if we went to them a year from now and we said, let's expand the formulary, I think that would be definitely something we could discuss. It wouldn't require a brand new program.
Yeah. I'd be curious. The Political article, I think, mentioned a little bit on how you're going about proving safety, that for each medication, the first like 250 are reviewed by a
Yeah.
human or something like that. Could you talk a little bit about how that's baked into this process and how you're thinking about that?
Yeah, I mean, there's always this like I think we do not want to be seen as like cowboys, right? Going out there and just like jumping the line. That's not a safe and effective approach to this. This needs to be sustainable. The way we set it up is of the medications on the formulary, we broke them up into 9 subcategories based on the diseases that you're treating. So there's cardiometabolic, there's mental health, there's women's health. Each one of those needs to have at least 250 done. And during those first 250 for each category, there is actually a physician that reviews what you would consider a full SOAP note or a doctor's note that's written by the AI
Mhm.
after the administration. The patient doesn't necessarily see that. From the patient's perspective, the AI says, yes, this is okay for renewal, and I'm sending it off. But the doctor actually looks at it and is that final gatekeeper. And so what the doctor sees is, this is the medication, this is the patient, these are the safety checks I did. these, this is the history, the patient's taking it, it's working, and whatnot. And then they say, yes, that's okay. And then, so after you get to those 250, we then review a subset of the next phase. And the subset is 10% of medications that come through. That's done retrospectively, though, that we don't stop the medications at that point. So doctors will then be sort of independently reviewing the decision made by the AI for 10% of those patients. And then phase three is, just a random sampling that is done, no longer some specific number that needs to be done. And, what we will be doing is obviously comparing what the doctor's what the doctor review was compared to what the AI review was, trying to identify whether or not there were discrepancies there. I think we'll probably take it a step further. It's not part of the Utah agreement, but we probably will have doctors independently review the medication renewals without the AI summary and see if they match, just to see which one's better, which one's worse. We did this actually in a study that we put out in June. Um, my having done this myself, my sneaking suspicion is that it's very hard for a doctor to match the like sort of rigor that these AI systems have. They just don't have the time, right? Like we do half a dozen safety checks that probably take a doctor an hour to do through our AI system before a prescription is renewed. The doctor is not going to do that for each renewal. There's just like no way that they have the
Yeah.
bandwidth to do that.
Yeah. It's one of the interesting observations I've had on new technologies when they come to market. The safety bar that you get compared to can be there are no errors versus the existing safety bar where there are inevitably errors that come to market. And I think part of what happens in that is the powers that be. I noticed in the article there was an AMA quote talking about the risks of not having physicians in the loop and so on and so forth. And you can imagine the press coverage the first moment there's an error where providers say, "Hey, what's going on here? We need to be in the loop." How do you think about that provider buy-in, the political risk, even if you are significantly more safety than the status quo or safe than the status quo, there still are going to be some errors and there's issues with that.
Yeah, I mean, I think first is setting expectations, right? Like going around and saying, like,
Hmm.
the bar we're getting measured against is not zero errors, right? Like that's impractical. It's, are we providing better care than the standard, right?
Yeah.
And making sure that people know that. Inevitably, there will be people that will come along and say, you made a mistake and it was one in 10,000, and you should be held liable for that, and we need to throw this away. I don't think that necessarily will be as powerful a voice as we think it will be. And you can see that with driverless cars today, right? The driverless cars, there was a lot of noise when they first launched. Oh, they're not safe. Every article that came out, there was a cat that was run over in San Francisco. There was a big article about that. And then all of a sudden the data came out, right? And we probably all read the article that came out of the New York Times. I think it was Slotkin that wrote it, that essentially said, like, look, it's not only safer, it's like, exponentially safer to be in a driverless car, right? And so in the end, you gotta wait for the data, I think is the answer to it, and make sure you set
Yeah.
expectations.
Yeah. And the other part of that I'm curious about, and I wrote about this a little bit in the newsletter this weekend, this idea that patients, if they have the choice, are going to choose human interactions versus interactions with chatbot, AI, whatnot, and recognizing that in rural areas, it might not be an opportunity for them to have the human interactions. But how do you process the role of AI medical group, chatbot only versus providers in the loop, when and where that happens, doesn't happen, and how you think about that framework?
Yeah, so first of all, I don't know if that's true, what you just said. Like they're always going to choose a human provider over an
Sure.
AI. In fact, what we've seen is it's just, there's this old saying in medicine, it's about, accessibility, being affable, and being able. Those are three A's to like creating a medical practice. In the end, it's really just about accessibility, accessibility, accessibility. And so what we have really found is that while people do state that they want a human doctor sometimes, if there's something else accessible, they're going to do it immediately. I think that's where they're probably going to gravitate towards. When it comes to, is it an AI only? Is it an AI with a doctor? I think there are certain things that AI only probably should take over, right? Like renewals are an obvious case, right? Like you don't need a doctor to be spending 6 hours a day going over renewals for medications that are safe and effective. There are areas where you do want a doctor involved. And the obvious one there is when there's no right or wrong answer, right? There are lots of situations within medicine where you don't have enough information to have an algorithmic response, right? And in that case, what you do want is a doctor, a human doctor, to sit down with you and actually have an open conversation about what are the risks, what are the benefits, and come up with a plan based on that, as opposed to an AI system doing that. So those are sort of two obvious like ends of the spectrum. In the middle, somewhere we'll meet probably, right?
Yeah, for sure. It's going to be an interesting journey.
Yeah.
I that much I'm fairly confident in. I'm curious to shift a little bit to how the pilot relates to the overall business. I think it was September y'all announced the Series A 25 million buck round. In that round, you talked about hitting 50K weekly visits, 1 million unique visitors. The entire rural population of Utah, I think, is around 350,000. You talked about having a few hundred visits in. So as you think about the business on the whole, relatively small portion of
Yeah.
what's coming through the platform, how do you think about the importance of a pilot like this in terms of the overall business trajectory over the coming years? Like, where does it fit in strategically?
Yeah, I mean, I think if you look at the pilot, obviously from a pure number standpoint, Utah's way too small to really make a big have a big effect on our overall number, our
Yep.
overall revenue. It is a proof point, a proving ground for sort of what I would call version 2.0, right? Like right now, version 1.0 is the AI. It's an AI native system where the doctor is always in the loop, and you have you're relying on doctors. The one that we're building today is a totally different version. It's a totally, for all intents and purposes, a different product. I mean, we spent a long time building the product for Utah. It
Hmm.
is far more robust than the product that is live today because it has to be, right? Like there are no doctors overseeing it. And so that allows us to build out a product that can now be rolled out to other parts of the country as well. We are also in discussions with a lot of other much larger states that have sandboxes. I would
Hmm.
anticipate 3 to 5 more states would roll this out this year. I don't know if that'll happen or not. Can't predict the future, but I can tell you from conversations, there are 3 to 5 other states that are considering something like this, right? Texas
Yeah.
being the biggest one out there. Texas just opened their sandbox actually January 1st. They're very interested in something like this. They're very interested in AI. All of a sudden, you go from 3 million people in the state of Utah to 32, 38 million people in Texas. And now it actually can have a huge impact on your business. I think the last thing I would say is think about when people change their doctor and so if you have a primary care doctor, when do you leave your primary care doctor? And the answer is only when you move usually, right? Like it's pretty rare. It's a very sticky event. And so from a business perspective, being able to offer autonomous prescription renewals to people who will potentially be on that prescription for 15 to 30 years, that's a very sticky event, right? And so it's really
Hmm.
important to actually get out first and be able to offer that first because a lot of those people are gonna, if they trust you, be with you for the next 30 years. And so
Yep.
it does become really important for our business in the long run to actually be in a place like Utah or a place like Missouri where there's small population, but we can essentially start building that relationship with our patients for the long run.
Yeah. Now that you've got V2 built and live in Utah, what's biggest gating factor to like why not flip the switch, do it all 50 states? Is it regulatory frameworks,
Regulatory.
economic? Like what's
Fairly
regulatory?
regular. We could
Yeah.
we could open this up to the entire United States tomorrow if we wanted to. The system is robust enough, and the scalability is like infinite with this. So it's definitely a regulatory issue right now.
Yeah. And on that front, I'd be curious. One of the things I saw in the Political article was that it looks like y'all have you called it a unique malpractice agreement where you do have insurance now that you're a practicing provider. Um, how do you think about malpractice and how that changes in a scenario like this? Like we saw last week, Pernuvo is having their own set of issues with the malpractice lawsuit um, over their scans. I'd be curious how you think about that in the context of the two of this offering, how you're rolling it out, et cetera.
Yeah, I mean, I think that there's always been this worry that, a company's going to come along and essentially try and do the things that a clinical, like a practitioner does, like what a doctor does,
Hmm.
but not want to take on the risk, right? Like, and say like, you know
Right.
what, I'm
For
still going
sure.
to dump that on a doctor, right?
Yeah.
And that may have
Totally.
actually been what happened in that particular case you're referring to, right? Which is they're essentially saying it's not our fault, it's the doctor's fault that was reading the scan. And in the end, maybe I don't actually know the full details of it, but there's
Yeah.
speculation that a doctor never actually read the scan. It was an AI output. We've taken a very clear, just made a very clear decision here that we do want to take, we're going to take on that risk because we want to own the clinical decision process. I think that's important for building trust with patients, but also just saying like, look, this is real. Like we're not trying to do this and subvert like the traditional way people take on risk. We're trying to do this in a very sort of thoughtful way. And so that's
Yeah.
why we went out and got that malpractice covered, which was quite hard, to be quite honest. Like start
I'm
talking to people
sure.
about getting, hey, we'd like to get malpractice. And they said, sure. Do you want us to cover the doctors? We said, there's no doctor. And then, it took like 7 times for us to tell them there's no doctor before it registered. And so, I mean, I think you need to own the risk if you want to own the process, right? In my view.
Yeah, for sure. I'm sure you guys are going to be getting a lot of pings about who you use for malpractice insurance for a doctorless product offering.
I'm not sure they
I
want us to reveal that, right? Like,
yeah, no, I get it. I'm curious on this regulatory framework conversation. There's the dynamic of state-based frameworks for practice of medicine versus FDA and the federal level. Certainly in the tech-centric circles I read online, there's a perspective that federal government's got to get in front of all the state activity from an AI perspective. So it's interesting to see in your scenario talking to states, leveraging states to actually drive this activity forward. How do you think about kind of this evolving regulatory framework between states, FDA, federal regulation on the whole, and what's your thought on path forward?
yeah, I mean, from a like industry specific point of view, it was clear to us that this is the practice of medicine, not
Mm-hmm.
a medical device. And the practice of medicine is like it is crystal clear that's regulated by states. And so that's why we went to the states and said, hey, we think this is a practice of medicine. Let's regulate it this way. Let's mitigate some laws. I think because of that, a lot of this probably will happen at the state level, at least when it comes to
Yeah.
healthcare. And obviously, the first time somebody does something, it becomes kind of a benchmark. So it
Mm-hmm.
may just turn out like, oh, we did this. The state of Utah approved a sandbox regulatory framework. Other states will follow, and then it just becomes a sort of the standard which people follow, and the federal government may not get involved, or they may say, you know what, we actually want to start regulating this. I don't know how that'll play out. But I think it's a little bit unique to healthcare in that, like, because the practice of medicine is regulated by its states, it just became an easier way for us to approach that problem.
Yeah. And last question, kind of on the state regulatory front. So there's in rural health conversations, there's the Rural Health Transformation Program that's gotten a lot of funding. States just announced their award. It was interesting to me to see Utah in their application mentioned they wanted part of it was to deploy consumer-facing tech, AI solutions, and automate prescription refill requests, among other things. Does the pilot relate? Like, are you having conversations about rural health transformation program as you think about these rural activities, or is that entirely separate bucket of work in your mind?
So they're not connected physically, or like there hasn't been an actual connection. I think there's an obvious synergy that people
For sure.
recognize when we do that. So like we started
Yeah.
talking to Utah, a lot of people within Utah said, "Oh, look, we have a lot of a big rural population. There's a lot of funding related to that. How do we connect the dots here?" But they
Hmm.
are, for all intents and purposes, right now independent. But hopefully, as the product matures, we'll be able to leverage some of those resources.
Yeah. If you had one piece of advice for states thinking about the regulatory framework and like rolling out V2 of something like this, what do you think is most important to clarify as we're figuring all this stuff out together?
That's a really, really good question. So I think first, I always start with like, what's the need of the population, right? Like, how
Hmm.
can we create regulations that are meeting the needs of the population? Utah did a really good job of that. And then the other thing that I thought Utah did a really good job was like, let's make this a data-driven sort of progressive process, right? They started off
Yeah.
saying like, okay, you think you can do autonomous renewals? Let's prove it with the data, right? And so I would suggest states take that approach as well. That can be hard, right? One of the good things about Utah is that their AI sandbox is run by the Department of Commerce. they obviously have a
Hmm.
different mindset than some of the other sandboxes that are overseen by different organizations. Like if the Attorney General's office is running a sandbox, they're going to have a different mindset than the Department of Commerce. And having the Department of Commerce or sort of a pro-business group running it, they just had a different sort of approach to it, made it a lot easier for us to navigate some of the thornier issues.
Yeah, for sure. So, as an outsider to the business, wanting to follow along on the pilot project, I'm always interested to hear like how do you recommend we keep an eye on what's going on if the project is being successful, hitting its targets, whatnot? Like how do you advise we keep an eye on what's going on in Utah as a community?
So I think there's a couple things you can like. One is we actually want to share the data with people. So you'll just look for us like
Cool.
within the first 3 to 6 months. We plan to share the data that we're gathering with everybody. We think that this is a rising tide lifts all boats scenario. And so, we'll be able to do that. I think also look at other states as well, right? Like if other states quickly start following Utah, I think that's also an indicator that there's an appetite for this and it's going to move a lot faster
Hmm.
than some people thought, right?
Yeah. Well, Alex, I know we're getting to the Adam. I'm sorry. I know we're getting to the bottom of the hour. Clearly end of day. My time. Appreciate you joining us. This has been a really fun conversation. It's been fun learning about the pilot. Any parting thoughts for you? Ways the community can get in touch, learn more about what's going on?
I mean, we're always looking for really smart people who are really passionate about changing the way healthcare is delivered, who really are engaged with AI to join our team. And so that's certainly one avenue. And beyond that, you can support us on, social media.
I dig it. Dr. Adam Oskowitz, thanks so much for joining. Appreciate the time today.
It's a lot.
See
Bye.
ya.